Dr. Bukari is an associate clinical professor in hematology and oncology at UCSF Fresno. He's the director of the Sickle Cell Program at Community Cancer Institute. He is board certified in internal medicine, pediatrics, hematology, and medical oncology with expertise in malignant hematology and I can't even speak today, hemoglobinopathies and thalassemia. He completed his residency in internal medicine, pediatrics at Wayne State University, which I know is a very good university. He's in his fellowship trained in hematology and medical oncology from Wayne State University at Ramos Cancer Institute. During his fellowship, he served as a chief fellow. Dr. Bukari is the recipient of the 2021 Henry J. Kaiser Award for Excellence in Teaching, UCSF Fresno. He is also a member of the American Medical Association, American Society of Clinical Oncology, and the American Society of Hematology. Dr. Bukari's research interests include adolescent, young, adult, acute lymphoblastic leukemia, and myeloproliferate disorders and sickle cell disease as well. So let's give a big round of applause. Welcome to Dr. Bukari, a very well-educated man, and we're ready to learn. So take it away, Dr. Bukari. Welcome.
Thank you. And I'm going to share my slides. And so I will get started. So iron overload in sickle cell disease is actually one of the new areas that is becoming very important. And part of the reason is not because this is new in sickle cell field, but because sickle cell patients are living long enough. Therefore, there are certain complications that 20, 30 years ago, we didn't see that we are beginning to appreciate. And so nowadays, we are very aggressive in managing iron overload. It's actually one of the most common, or one of the common causes of death in sickle cell disease because of the effect of iron overload on the liver, and then in the heart and other organs like pancreas and other endocrine organs. So the goals of my presentation today is overall to create awareness of iron overload and its effect on sickle cell disease. And for those who are patients or patient advocates or patient family, to create this awareness so that you can talk to your providers about iron overload and what you can do to mitigate it. And, you know, it also allows you to be aware of some medications that are being used to treat this condition. And it may help you understand why you are given what medication for iron overload and the importance of compliance. Objectives include, I will review iron homeostasis, which is pretty much how iron is utilized in our body, starting from intake and absorption, and then how it is broken down or metabolized and how it is eliminated. And then evaluation of iron overload in sickle cell patient and treatment of iron overload, as well as prevention. Feel free to either stop me to ask a question. I would like it to be as interactive as possible. So, as part of my introduction, iron occurs in three forms. There is iron 2+, which is usually what is in most of the medication, even though some medications may have iron in 3+, but by far, iron in 2+ or ferrous form is the most common. The 3+ is the ferric form. We also have iron in proteins, for instance, heme protein, which is found in meat and meat products. Overall, iron is stored in the body in a form of hemoglobin. So hemoglobin is the highest storage organ or tissue ion. And then there are other proteins like muscle protein or myoglobin or cytochrome enzyme, which are enzymes that are responsible for energy transfer and release. And then iron is also bound to iron protein called transferrin in plasma, which is a small, very, very tiny component. And then in the tissue, or other tissues like liver, pancreas, some muscle, bone marrow, iron is stored as ferritin or hemosiderin. So moving on, I will talk about how iron moves around the body. Let's start with the center of the picture you see where you have plasma. So the plasma ion, which is the transferrin, or small part of ferritin, which is in circulation, obtain its ion either from absorption. So if you move the arrow to your, or to the left of your screen, absorption, which is about 1 to 2 milligram daily. And then ion is lost through daily loss through the GI or skin, which almost equate the amount of iron that is absorbed. And then there is ion in the system, which either comes from body storage of iron, which is about 1,000 milligram or 1 gram. And then from other systems like the muscle, enzyme, and all that. And so iron moves into the plasma or moves from the plasma into these organs. And the plasma ion is transported to the bone marrow where blood cells are formed, and the ion is incorporated into the red blood cell or heme protein of the red blood cell to form hemoglobin. And then the hemoglobin helps to carry oxygen around our body. And when the red blood cell becomes old, and old means it reaches the end of its lifespan of about 120 days, but a little shorter for sickle cell patient, the ion there is released into reticuloendothelial system, and part of it is transported back into plasma to be recycled. So majority of the ion in our body is recycled ion, and this is replenished with ion intake from food, and then it is balanced with ion losses from dead or dying tissues, including skin cells. So overall, iron is one of the metals that is tightly regulated in our circulation and in the body, because the free ion can has a detrimental effect in our body, and we will see this in the next few slides. So this is another breakdown of how iron is circulated, starting with ion absorption in the intestine, where there is ion channel, which allows ion to move into the intestinal mucosa or the lining of the intestine. And here the ion moves out of the lining into circulation, where it is bound by ion transporting protein called transferrin. And from there, it is then transported to other organs that need iron. For instance, the bone marrow, and if there is excess iron available, it is transported to the storage organs. So next is, why is iron toxic? So generally speaking, the ion or ion molecule or ion metal is bound when it is in circulation or storage. In circulation, there is an ion binding protein that binds the ion and prevents it from becoming a free ion. Free metal in circulation has the potential to cause what we call oxidative injury, because in the presence of free radical, the free ion is converted from ion 2+ to ion 3+, and this ion becomes very toxic to the body. And within the cell, there is also ion, which is bound with another protein in order to prevent it from being free and causing injury to the cell. So how does it cause injury to the cell? In the presence of reactive oxygen like hydrogen peroxide or hydrogen superoxide or other hydrogen atoms, the ion becomes oxidized. And when it does become oxidized, it becomes, it binds to certain protein, or it has a direct injury effect on the cells. And the cells can include the liver cells or hepatocytes, the pancreas cell, or wherever iron is stored. So how do we get iron loaded in patients or individuals who are non-transfused? So sickle cell patient or thalassemia patient who are not transfused. Remember, I mentioned that the only way to get iron into your body is by taking iron either in food or in medication. So here, when you take iron in food or medication, part of it is absorbed. And in sickle cell or thalassemia patient or patient with hemoglobinopathies, there is what we call ineffective erythropoiesis, where the body is making some cells, but the cells either are not stable and die too early, or under certain conditions, they undergo what we call hemolysis. Therefore, the body has high turnover of iron. Okay, so some of it is absorbed, and some of the iron is lost through urine or through the skin cell. So if for some reason an individual takes in either more iron in food than required, for instance, some patient will just go on either iron-rich medication or iron-rich food or iron supplementation for whatever reason. This balance is the balance is interfered, and there is increased iron intake more than what you lose. And therefore, the excess iron is then stored in organs like the liver, the pancreas, bone marrow, and some other organs like the thyroid, the ovaries, and so on and so forth. So overall, we use, since ferritin or ferritin protein is the protein that is in the tissue, and that is the protein that binds to iron and prevents it from being available as a free metal. We use ferritin level as a measure of total body iron. It is not 100%. It's not, the correlation is not 100%, but it provides us with the best estimate of how much iron you have or how much iron is stored in your body. So overall, if a provider or sickle cell specialist or thalassemia specialist wants to measure how much iron an individual has, we use a test called serum ferritin level. Unfortunately, this same protein is also what we call acute phase reactant, or it's elevated in some other conditions, like when you have inflammation, some infections, or combination of infection and inflammation. So generally speaking, one measurement may not be enough to tell us whether you truly have iron overload or the high ferritin is because of inflammation. We usually rely on what we call baseline ferritin level. So we measure the level when you are not sick, you don't have infection going on, you are not having sickle cell pain episode or crisis. That will give us what we call a steady state or baseline ferritin level. And we can use that as a guesstimate or best estimate of how much iron storage you have. What about patients who are transfusion dependent? So I mentioned that for patients who are transfusion independent, the only way you can become iron overloaded is if you take in more iron than the body needs. And this can be in a form of food or medication or combination of food and medication. For patients who are on transfusion, or for sickle cell individuals who are on blood transfusion, either in a form of simple transfusion or chronic transfusion to treat specific condition in sickle cell, like patients who have history of stroke, we put them on chronic transfusion program to prevent the stroke from happening again, or when you develop certain complications like acute chest syndrome or stroke, we use transfusion, exchange transfusion to kind of treat those conditions. So those who are transfusion dependent, either as part of chronic transfusion or intermittent transfusion to treat specific sickle cell complication, they can become iron overloaded as a result of additional transfusion they receive, because of for their condition, in addition to oral absorption from either food or medication. So this is the reason why we always educate patients about judicious use of blood transfusion, because the more blood you get, the more iron overloaded, the higher the likelihood that you are going to get iron overloaded. So we always counsel patients and providers on judicious use of blood transfusion, and transfusion only if it is absolutely necessary. And the necessity will include if a patient has symptoms of anemia, or if they have complications of sickle cell that necessitate the use of transfusion, like stroke, acute chest syndrome, or severe anemia from excessive hemolysis, then yes, you should use transfusion. But you have to always evaluate the need for ongoing transfusion, and as soon as you possible, you need to begin evaluation of potential iron overload and treatment of iron overload. So how much transfusion, how much iron do you get from transfusion? For every 1 unit of blood, and the unit of blood can range from 250 and in some situation up to 350 mLs. Each unit of blood will give an individual 200 to 250 milligrams of iron. So think about it this way. If you are always getting transfusion every month with only 1 unit to treat your anemia, it means you are being given an additional 200 to 250 milligrams of iron. A single iron pill contains about 65 milligrams of elemental iron, and of which a very small percentage get absorbed. So maybe 1 to 2 milligrams gets absorbed. So if I give a sickle cell patient or thalassemia patient or any other patient for that matter 1 unit of blood, I'm giving you about 200 to 250 milligrams of iron, which if you look at the amount that you need to take, so if at best you absorb 1 to 2 milligrams of iron from iron intake, it means you would have taken iron for a month in order to get to what we just gave you, okay? And so anytime we give somebody transfusion of 10 to 25 units of RBC in their lifetime, there is a good chance that they are iron overloaded. So think about it. When sickle cell patients are young, they may be getting transfusion for other reasons. So if you add it up, if somebody gets a total of 10 units of transfusion for whatever reason, their risk of developing iron overload increases. Okay, so some institutions actually start iron chelation when you just mere fact of receiving 10 to 25 units of iron, because the risk of iron overload just goes up. Or if we talk about iron overload possibility, if your ferritin is greater than 1,000. And here we are talking about baseline ferritin. It's not ferritin level when you are sick, but when you are well and nothing is going on. We also talk about possible iron overload when we measure what we call liver iron concentration. And this is done using an MRI. We do a special MRI and they are able to measure the amount of iron per gram of liver weight. And when the level goes above 3 milligrams, there's we say there's iron overload. The cutoff we use, however, to start somebody on chelation actually varies from institution to institution, but by and large, most experts agree that when your serum liver iron concentration is more than 7, you should be on iron chelation. Between 5 and 7, we have to individualize, and maybe for patients who need ongoing blood transfusion, definitely should be on iron chelation. And there is another measure of iron overload called cardiac iron level. And here we use conduction of electricity through the heart. And if the conduction is high, then or the degree of conduction is high, then we estimate iron overload in the heart. But by and large, most institutions, we use first serum ferritin, and then if the serum ferritin is high, we confirm iron overload with doing what we call liver iron concentration measurement using MRI to confirm iron overload before we start any treatment. So this is just to give you an idea, the differences in iron overload depending on what kind of transfusion program you are on. For instance, the highest iron loading occurs in the dark dots, where the dark dot is when a patient is getting simple transfusion. So the worst thing that can happen to anybody is to be on simple transfusion program, where you need, it is determined that you need blood transfusion, and it is if especially it's chronic blood transfusion, they are just giving you transfusion every now and then. So there are some patients who actually demand transfusion when they go to the hospital because they are anemic, even though they absolutely don't need transfusion. And in my practice, this is one of the areas that I spend time on. And I educate patients on the fact that anemia, not all anemia means the need for transfusion. We have to make sure that you have symptoms of anemia. And the symptoms of anemia can include dizziness, lightheadedness, especially when you stand up from sitting or lying position, heart palpitation, sometimes chest pain, severe fatigue. But we have to make sure that there is no other explanation for this, and anemia is the explanation for this before we recommend transfusion for patients. And if we do recommend transfusion, we want to give as minimum as possible to resolve the symptoms, because we know that the more transfusion we give you, the higher the likelihood that you're going to develop iron overload. And then the next type of transfusion is what we call manual exchange. And this is a common practice some time back, and is still being practiced in poor resource environment, where when the child is too young to be connected to exchange transfusion or automated machine. And here, when they determine that you need blood to treat sickle cell complication, what they do is they take a little bit out, they give you a little bit, they take a little bit out, they give you a little bit, and until the amount of blood that is estimated that you need replaces whatever they take out. And this allows us to exchange blood, normal blood, for sickle cell blood. And occasionally after the exchange transfusion or manual exchange, we may give you a little bit more to correct whatever anemia you have if we make a determination that we need to correct anemia in patient. But by far the best way to administer chronic transfusion is using automated machine. And it's called apheresis machine, where individuals with history of stroke, if we are planning to put you on chronic exchange transfusion to prevent stroke from happening, or if individual get admitted to the hospital for acute chest syndrome or stroke or priapism, and we make a determination that they need exchange transfusion, they are connected to apheresis machine, and the machine is programmed to exchange sickle cell blood with normal blood, or I won't say normal blood, but non-sickle cell blood. And then we also calibrate it to set a set level of hemoglobin at the end of transfusion. And this may be done one time, or it may be repeated for patients who need monthly transfusion on monthly basis. And this is one of the best to at least reduce the likelihood of iron overload. And so why are we worried about iron overload overall? So this is very important. And this is based on data that we have. The first one, or the first point, they look at sickle cell deaths. And this was done in Washington, D.C., University of Howard Hospital. They look at sickle cell death over 25-year period, and they found that about 1 out of 5, approximately, or 17% approximately, either has direct relationship with iron overload or complications that resulted from iron overload. In another study that was done, and they look at sickle cell patients who have had at least 10 units of transfusion per year, and those with iron saturation greater than 50%, they found that mortality or likelihood of death is higher in those patients compared to those patients who are not transfused or iron saturation less than 50%. So when you look at mortality, 6 out of 10 for patients who have high iron or high likelihood of iron overload compared to 5% or 5 out of 100. And then they also evaluated the likelihood of iron toxicity to the heart. So, majority of patients who have iron overload who die, they die either from complication in the liver or complication or the effect on the liver or effect on the heart. So when they look at likelihood of iron toxicity, they found that 2.5% of patients who are chronically transfused are likely to have cardiomyopathy or evidence of iron toxicity in the heart. So this is the reason why overall we are very aggressive nowadays. And again, because patients are living longer, before life expectancy of sickle cell is maybe 30 years at best. But now, overall, across board in United States, the life expectancy is increasing, and some estimate put it at maybe 60 plus years. In California, it's a little bit lower, about 42 years, but it's still better than before. We could do better. And the longer we live, the more likelihood that iron overload will become a problem, especially for patients who are getting intermittently transfused. And you can understand why, if you see a 1-year-old sickle cell, likelihood of being transfused is probably lower, but the older you get, even if you get 1 unit every years, by the time you get to 20 years, you would have accumulated 10 units. And your risk of iron overload would have been high. Fortunately, for sickle cell females, and I always would like to make this statement, it is still possible that if you are a female and you are menstrual and you are a sickle cell patient, you could be iron deficient. And in my practice, I've seen this happen. Just last week, I saw one young lady, sickle cell SC, who had, relatively stable hemoglobin, but the iron parameters are very low, which means that they have iron deficiency. These are the patients that even if you have to do iron supplementation, we do what is called time-limited supplementation. So when I put you on iron, I don't just give you indefinitely. I say, take it for 1 month. And after a month of treatment, we check again. And I make sure that, if the iron level is back to normal, I counsel you, don't take it again. Don't take it without, instructions from me. And just an example for this lady, after 3 months of iron treatment, her iron is still low. So I told her, we're going to take it 1 month at a time, and then we're going to recheck. So that's a very important information to have. So if for whatever reason you were determined to have iron deficiency, when the doctor says stop the iron, you need to stop. Otherwise, there's a good chance that you're going to create problems down the line. All right, so the tissues that we use to estimate your total body iron, liver concentration it provides us with the best estimate. So a recommendation is to do a liver MRI and use the amount of iron deposit in the liver as the estimate of your total body iron storage. Sometime when we do MRI, it gives us information about pancreatic iron or pituitary or cardiac iron, but they are not a good estimate of your total body iron, but they provide us with important information, because if you already have iron overload in pancreas and pituitary gland or ovaries or the testes, then definitely your chances of complications from iron overload is high, and we are very aggressive with those kind of patients. And this is just a graph telling us how quick iron overload can occur. So let's focus on the dash and dotted line, which is iron in the liver. So, at the beginning, when you look at sickle cell patients across board up to age 24, you realize that the liver iron storage is stable at the beginning up to about 15 years. And then after that, it starts going up. And it's because most patients, when they are pediatric, their care is under the care of their parent. And so things are much more controlled. And unfortunately, what we see is once you turn adolescent, young adult, then patients are taken care of in adult hospital. Unfortunately, most adult hospital, when you have anemia, hemoglobin of 6, the reflex is to give you blood. And so we always counsel patients, if you go to the hospital and they recommend you to have blood transfusion, you need to ask them, did you talk to my sickle cell doctors? Or if you are not sure if they did talk to your sickle cell doctor, most of my patients actually do call the office and say, just so you know, I have an order to have blood transfusion. I want to make sure that you are aware of this, and if it is okay for me to receive blood. because of, and the reason why we educate them on that is because of this curve. We know that the period adolescent, young adult period is the time that individuals accumulate iron in the liver quickly. And the iron accumulation in the heart and pancreas does not happen early. It's a late occurrence, but when they do occur, the accumulation is pretty fast. So what are the signs and symptoms of iron overload? Like I said, we don't want you to even have signs and symptoms, because by the time you have signs and symptoms, it's probably too late. We don't want that to happen. I don't want my patients to have any signs of and symptoms of iron overload. And partly because I feel if I wait, if you develop signs and symptoms of iron overload, I failed you partly because it means I did not, look out for high risk iron overload situation. I did not check your ferritin level. I did not evaluate how much transfusion you've had in the past, and I did not start you on medication early enough to either reduce your iron concentration or prevent iron overload. But if the iron overload occurs, the signs that you have will include abnormal liver enzyme. The liver enzyme that we look at include the AST or ALT or ALK-phos, and then bilirubin. We know that sickle cell patient will have high bilirubin anyway, so I don't place too much emphasis on that, but AST, ALT is something that I look at. And then cirrhosis of the liver is also a late sign of liver iron overload. There are other causes of cirrhosis, including hepatitis, alcohol, and sometimes hereditary iron overload. But if you have iron overload, you can develop cirrhosis and liver failure. And then for the heart, congestive heart failure and sometimes rhythm abnormality, you may have high heart rate or low heart rate or irregular heart rate. And sometimes you have what we call cardiomyopathy, where the heart either loses its conduction ability or pumping action. And then in the pancreas and other endocrine organs, diabetes, is also one of the signs or symptoms. And then for males, hypogonadism or low libido because of effect of iron on the testes, leading to decrease in testosterone. And impotence is also possible for women, infertility or premature ovarian failure because of effect of iron on the ovaries. And for the bones and joints, some people will just have generalized bone and joint pain from iron overload. And this can make even sickle cell pain much more confusing. Some patient will tell you, I know this doesn't feel like my sickle cell crisis. It just feels different. It's more in my joints, and diffusely in my bone. And I know that my sickle cell pain is in specific area of the bone, but this is just everywhere. Okay. And so how do we screen for iron overload? And this is one of the most important information that you need to have. First, we look at when the first time we see patient, especially if you are transitioning from pediatric to adult, or you are seeing a new sickle cell provider, they need to estimate the number of transfusions that you've had. So usually I ask the patient, in the last 1 year, have you had blood transfusion? If you say yes, I ask how many? And then I extend it to, okay, in the last 5 years. And then I say, okay, usually, how often do you get transfused? And then patient can say, I sometimes once every couple of months, but I remember so and so I had several units because I was sick. And then the other way we screen is to do what we call ferritin level. most institutions or most sickle cell offices will do this every 3 months, at least until they know the patient well, and then they can do it once a year. But overall, most people will do it every 3 months. And the most recent recommendation is, if a patient is a high-risk patient, maybe once a year, you need to document the liver iron concentration. If you have a documented liver iron concentration and it's so low, then you can actually be a little more flexible and check it maybe every couple of years. But for those who have liver iron overload, but they are not at the threshold for consideration for treatment, at least once a year, they should have that check. As for cardiac iron, the testing can be done, especially for patients who already have liver iron overload and they are on treatment and their treatment is not going well. Then you can add cardiac iron overload as annual test, but generally we don't do that. We do it on specific condition as needed. Okay, so just to sum up, the must do is number of transfusion, lifetime transfusion, yes. Sometimes we do 3 monthly ferritin level. And if a patient is very stable and their ferritin levels are very low, then you can, become a little more flexible on that. And for patients who are high risk, at least once a year MRI. But depending on the patient's clinical condition, if their risk is very low and they already have one relatively normal liver iron concentration or liver MRI, then you can, extend it to every couple of years or every 5 years, but that needs to be determined by the provider. And we generally reserve cardiac iron overload testing annually for only patients who have significant liver iron overload, who are not well controlled, and you are concerned that there's a good chance they will develop cardiac iron. And the reason why you want to do check is to make sure that you optimize their iron chelation and to prevent complications. And then how do we diagnose though? So the screening is different. Diagnosis is screening means you are doing tests to catch the condition early and consider treatment. For diagnosis, by and large, we use liver MRI. So if I do a screening test with ferritin and your ferritin is very high and I repeat it and it's still high, then I will order liver MRI. If for whatever reason the liver MRI is inconclusive or it's kind of abnormal, but your ferritin and the liver iron is not correlating well, the gold standard will be to have a liver biopsy. And the liver biopsy will give your provider additional information, including exact quantification of iron in the liver, and it will give you if there are other reasons. And if there are already damage to your liver from the iron. And then the cardiac iron overload, we do it particularly for patients whose liver iron concentration is more than 15 milligram per gram for 2 years. So remember I said that we reserve that for specific clinical condition or clinical situation, especially for those who have bona fide iron overload and they are not well controlled, especially if their iron concentration is more than 15 milligram per gram. And here is just to give you a definition of what normal and abnormal ferritin is. So normal ferritin, up to 300, low normal 300 to 800, moderate elevation is 800 to 1700, high is 1700 to 2500. But by and large, each practices or each institution have their threshold for using the ferritin as a screening. It's a screening test, so if it is abnormally high, most people will like to do a liver MRI to make sure that if the liver iron is meets the threshold for treatment, then treatment is initiated. If it doesn't meet the threshold for treatment, then monitoring plan is instituted. And then, here, liver MRI, we measure it in milligram per gram of liver. And like I said, most institutions will start treatment anything between 5 and 7, between 3.5 to 5. It depends on the clinical scenario. If you are high risk and there's ongoing risk of iron overload situation, then most people will start chelation early. And chelation is one of the things that we always say, or iron overload, prevention is better than cure. Because once the iron overload has already occurred to a certain degree, it's difficult to treat or to get you back down to where we want you to. And then, so when do we start chelation program? Most institutions, or the recommendation is when you make a determination that somebody is a candidate for chronic red blood cell transfusion, either simple transfusion or exchange transfusion or manual exchange or through apheresis machine. Because of the risk of iron overload, most institutions will start iron chelation at the same time in order to prevent iron overload. Most sickle cell providers will also start chelation when a patient has received between 20 to 25 units of PAC RBC, but nowadays we combine this with total body iron estimation, either using liver MRI or to really make sure that, yes, we are giving patient treatment that they actually need. And then the other thing we use is persistently elevated ferritin. And again, nowadays, because we have MRI, liver MRI, unless we cannot do MRI for whatever reason, there are some patients in whom MRI cannot be done because they have implants that are not MRI compatible. Then we have to use these other surrogate markers to determine when to start. But by and large, if your liver iron concentration is between 3 to 5, especially if it's more than 5, in non-transfusion dependent, then we try to start chelation early to prevent iron overload. So principles and goals of iron overload management. The goal is to decrease amount of iron in circulation, and because we know that the free iron in circulation or in tissue is what causes iron damage. And we use measurement of the ferritin level. We monitor the liver iron concentration, and if patient has iron overload in the heart, we also use cardiac iron. And the main aim is to maintain reactive free radical or reactive iron species at the lowest level, and then minimize the side effect of treatment, increase compliance, and to create patient-provider collaboration. I believe that if a patient understands why they are taking certain medication, the likelihood that they will be compliant is very high. So what are the choices we have? We have currently 3 different preparations in the market. There is an IV preparation IV or subcutaneous preparation called deferoxamine. Usually this can be given by IV or under the skin, and you use it is given multiple times or is administered multiple times in a week, and usually overnight, about 8 hours, 6 to 8 hours if possible. And it is hoped that this will help individuals who are iron overloaded to remove their iron, usually through feces and urine. And then there are 2 oral preparations that are in the market, the ferropron and the feroxyros. Generally speaking, in the United States, most of us will start with the feroxyros, which can come as S-Jade or Jade Nu. I think those are names that people are familiar with. And we start with certain milligram per kg, and then we make adjustment as needed. And then we monitor for side effects, which include diarrhea, nausea, vomiting, skin rash. We monitor your blood count closely if we are using the oral ion chelation. And the difference between the feroxyros, which is S-Jade or Jade Nu, and the ferropron is the ferropron you have to take multiple times a day. So that's why in the US, most people, the preference will be the feroxyros, which is once a day and easy to administer, and then we monitor closely. There are some patients who actually need combination because their iron is so high and they haven't responded well to what single agent. So you can combine the ferropron and the feroxyros, or the feroxyros and the feroxamine. So you can combine 1 and 3 or 2 and 3. So the first column is the ferropron. You can combine the ferropron and the third column, the feroxyros. Sorry, the feroxamine, the first column and the third column. Or you can do the second column, the ferropron and the feroxyros. Overall, what my clinical experience is that when you have combination, the side effect increases, so the compliance unfortunately goes down, and you make a determination to do combination because patient is not optimal on one of them. But by and large, I place emphasis on compliance, and I try to use only one agent if possible, and improve compliance and optimize the dose before I consider a second. So I talk about the combinations already. So this is number 1 and number 3, or number 1 and number, this is duplication, and then this is number 2 and number 3. And what other supportive care do we give patients? So for patients who have cardiac or heart ion overload, sometimes the cardiologist may use calcium channel blockers to help. And then occasionally we've added vitamin C, which has been shown to improve iron excretion. So we added low dose vitamin C. There are some evidence to suggest it helps. Some people use a medication called hexadentate phenolic amino carboxylate, which is ion chelator that is supposed to help. But by and large, we use the first 3 medications that I mentioned, and these are like supporting cast. So you have the main cast and supportive cast. And then in terms of monitoring, there are a few things that we monitor closely. Some of the ion chelation agents like the feroxamine affect the hearing. So at least once a year, hearing assessment and monitoring is required. And then eye evaluation. I think eye exam is one of the key things that sickle cell patients should remember to do. Sickle cell by itself has some eye complications that need to be determined early and be taken care of. The hydroxyurea also may cause eye toxicity. So all sickle cell patients, my recommendation is at least once a year, not optometrist, but ophthalmologic evaluation. You need to see the doctor himself, and they need to dilate your eye and look at the retina and make sure you are not developing any complication. And then we also monitor the kidney function and the blood count. And then we also monitor the liver function as well, because iron overload by itself can affect the liver, and medication can affect the liver. For pediatrics, excessive iron can cause what we call retardation of growth, because iron replaces calcium, and therefore you don't have optimal bone growth. So we monitor the growth chart as well. And then we monitor other endocrine function like, you know, you monitor for diabetes, you monitor the testosterone level, you monitor the thyroid function, especially for patients who have severe iron overload. So iron is one of the areas, or iron overload in sickle cell is one of the areas that truly represent prevention is better than cure. Okay, so as much as possible, we try to prevent it by restricting transfusion to only appropriate indication. So no transfusion for things that really do not require transfusion. And then, if possible, for patients who are going to undergo transfusion, especially if it is to treat certain complications like acute chest syndrome, stroke, or chronic transfusion, we want to make sure that we use automated machine, if possible. And this will allow us to properly replace the sickle cell blood with non-sickle cell blood and prevent over-transfusion. And then we need to optimize the use of disease-modifying therapy like hydroxyurea in order to, you know, hydroxyurea will help improve the hemoglobin, reduce hemolysis, and probably prevent transfusions. We will modify or we will optimize the use of disease-modifying therapy to prevent, you know, anemia and transfusion. And we always tell patients, you know, yes, you can take multivitamins, but when you buy a multivitamin, you need to check, sure that it is the one that stays multivitamin without iron. Or you have to read the label properly and make sure that the multivitamin doesn't contain iron. And if for whatever reason you develop a sickle cell patient develops iron deficiency, we always recommend time-limited supplementation and recheck in order to prevent iron overload. So I think this is the end of my presentation, and I would like to see if there are questions.
Yes, if anyone has any questions right now, just go ahead.
Fred Martha, in a short time, short period of time.
I think Alex are proud of Trump supporters, but and it could be the lynch.
Hello?
The former president more directly.
I had a question.
Yes.
Well, my first question, you know, me, myself, I have sickle cell anemia, and right now I'm currently taking a iron chelation, which is I believe it's the second one, I forget how to pronounce it.
Is it SJADE or JADE or the Caripron?
The Ferroprone, that's
Okay.
the one. And I'm taking that 3 times a day. I noticed the main side effect that I have, I feel a little fatigued from it, but it is helping get some of the iron out of my system because I have so much of it because my blood count keeps dropping. And for me, that's the main key is hydroxyurea pretty much the only medicine you can take to help keep your blood count at a stable level?
So far, yes. But occasionally for patients like you, if anemia is really one of the problems you have, there is another medication that voxelotor, which
yes,
sometimes we use to prevent anemia of sickle cell. It's not been approved specifically for that. But so in some of my patients, I've used it to prevent anemia in sickle cell because we know anemia begets transfusion, transfusion begets iron overload. And for you, since iron overload is one of your main problem and anemia, you know, is also present, you know, in addition to optimizing hydroxyurea, maybe adding voxelotor might be beneficial. And like
I'm sorry, what was the name of that?
voxelotor.
Voxelotor.
Yes. And like I said, it is not approved specifically to be used for that, but clinically we do use it.
How do you spell it?
Do you know how to
Dr.
spell it? I'm so sorry.
Dr. Bukari, are you talking about the new therapy that was produced by Global Blood Therapeutics, Veloxator?
Voxelotor, yes.
Well, you know, now they've given it another name. It's Oxbryta.
Yes, that's the trade name. I try not to use the trade name because usually in our presentation we try to avoid. So Oxbryta, yes.
Okay. Okay. So some people just may be more familiar with another. Yeah. Okay.
Yes. So
thank you.
like I said, I've had few patients who have severe anemia of sickle cell, and they are optimized on Hydria. You could use the Voxelotor to try and as an added therapy to hydroxyurea, and it may have an added benefit of improving the hemoglobin by reducing hemolysis.
Okay. And my last question, I apologize if this comes off a little simple, but are there foods that I could take to kind of help boost my oxygen levels, or foods that I can eat? Because I'm doing everything I can so I don't have to take so many blood transfusions, because, the iron, I don't want it to become a greater problem later.
Yeah, for you, unfortunately, we don't have specific food that directly help, but for all sickle cell patients, we recommend balanced diet.
Okay.
Balanced, normal diet, adequate protein, adequate fiber, adequate vegetables, fruits, balanced diet.
Okay. Thank you.
Thank you.
Hi, my name is Tracy. Hello, can you hear me?
Yes, I can hear you.
Okay, hi, my name is Tracy. I'm working with a 4.1 hemoglobin. I can't be transfused due to the fact I have a rare antigen. Also, I've been on Veloxator and hydroxyurea, and it wasn't effective. Now I'm on Epigen.
Yes.
And on Epigen, I'm on 30,000 units weekly. And that seems to be taking the hemoglobin up slowly. But my question is, I'm sorry?
Are you working well?
So far, I'm going to a nephrologist.
Okay.
I'm on a stage 3A.
Okay.
So they're not working. They're the stage 3A. So my question is, my hematologist asked why couldn't I be on iron, and I can't get transfused. So I haven't been transfused in years. Like I said, I have a rare and no blood in the world. We've already gone through that. So how can I tell? How could they tell? Or do I need iron?
Yes. So in your situation, the first thing to do is to check your serum iron saturation, and ferritin. If your ferritin is high, and usually high for kidney, for patients with kidney, we always say anything more than 100. And I suspect in your case, it's probably going to be much higher because most people develop antigens from transfusion. And I didn't talk about that because that wasn't the topic for this discussion.
Yes.
So one of the areas that I also counsel patients on as the main reason to avoid transfusion unless it's absolutely necessary, apart from iron overload, is development of alloantibodies like you did. And that's gonna make getting more blood for you very difficult. I've had few patients, anytime they need transfusion, and sometimes their blood comes from New York, from New York to West Coast, because they have a lot of antibodies to antigens that they can only, they are compatible to very few units of blood. In your case, I think your kidney function probably contributes to your anemia because the kidneys produce erythropoietin. And when your kidneys are working well, your bone marrow is dependent on your kidney to produce erythropoietin to compensate for the anemia. So now I think your kidneys may not be producing enough erythropoietin. And so it was a very good idea for your doctors to probably optimize you on the EPO that you're getting, because that might help, or that's likely going to help your anemia.
Okay, thank you.
So in addition to iron overload, transfusion also predisposes patients or sickle cell patient or any other patient for that matter to what we call transfusion-associated alloimmunization. In the layman's term, what that means is that if they give you blood from somebody, and then it is not 100% compatible. The way we do our compatibility testing, in the clinical practice, we don't do what we call phenotyping or genotyping. So especially if you go to a hospital that doesn't have sickle cell provider, they may not do a phenotyping or genotyping. Or if you need transfusion urgently, there will not be enough time for genotyping or phenotyping, and that will predispose you to developing what we call antibodies. And those will reduce significantly your chances of getting transfusion, compatible unit of blood in future. So, so it's really, really important that transfusion is used only when it is absolutely necessary. And if it is done, it is done judiciously. And if there is time to do phenotyping or genotyping, we should do genotyping blood, so that we reduce the risk of alloimmunization.
I have a question.
Yes.
Taking vitamins like B12, can that help when you're taking the medication for help with fatigue? Because, it does tire a patient out. Is that okay? B12,
Yes.
multiple vitamins?
Yes. So there are some vitamins that are called water-soluble vitamin. The vitamin Bs and the Cs are water-soluble. So by and large, they are less likely going to accumulate in your system, because if you have enough, you just pee it out. So those, I know that there are some patients who swear by vitamin B12.
Yeah.
And they tell you, you know what, that's the only thing that gives me energy. And even though the levels are not low enough for us to make a clinical decision to give the vitamin, but the patient swears by it. Because it's a water-soluble vitamin, I generally do not oppose it too much. Though I tell the patient, you know what, your vitamin B12 level is normal. I doubt if it is helping you, but if you say it's helping you, I don't oppose too much. On the other hand, vitamin A, D, E, and K. A, D as in dog, E as in Edward, and K. These are fat-soluble vitamins, and they have the propensity to accumulate if you use them in high doses and you don't absolutely need them.
So A, C, E, and K.
A as in alphabet, D as in dog, E as in Edward, K as in kin.
Okay.
The B and C, the B as in boy and C as in Charlie, these are water-soluble vitamins. So the chances of having what is called toxicity is way lower.
Okay.
All right.
Okay, great. Thank you very much.
Okay.
Okay. Any more questions? I know Dr. Bukari has limited time, so we'll take one more question. Okay, go ahead, Tracy, if you have one more question.
Yes, thank you. I know you have limited time, but I have a question. You said the best blood for those that cannot get transfused is New York. How do you contact that?
To do what?
You said the best blood to get transfused is in New York?
No, not New York. So what I was saying is they need to do what is called genotype or phenotype matched blood. And I was just giving an example of a patient of mine who has developed what we call antibodies, or who has developed antibodies to previous transfusion. And it was so difficult to get her blood. So anytime she needs blood, you know, the only compatible blood usually comes from New York, because there's probably somebody over there whose blood and this patient hasn't developed antibodies to.
Okay, yeah, I've been all around the world except Africa.
Yeah.
And that's our American Cross, and no one's been able to match me.
Exactly. So usually the Red Cross or the blood bank, they have partners when they have difficulty in getting compatible blood. They reach out to their partners, and this patient happened to be lucky that, you know, it looks like, you know, the blood bank in New York has a patient, a donor that actually is compatible to this patient.
Okay, thank you.
And we also, one of the things that we want to also encourage families of patients with sickle cell is to sign up for voluntary donation. It's going to help us. You know, sickle cell patients are one of the heavy utilizers of transfusion. So any help to the system is welcome.
Okay, thank you.
Thank you very much, Dr. Bukari. We appreciate, as some people in the chat have been saying, the presentation was super insightful, super informative. I agree. Definitely learned a lot today. Definitely need to brush up on my technical terms a little bit more. But other than that, this was very informative. Thank you very much, Dr. Bukari.